Good afternoon, everybody who's joined us for this parathyroid Q&A session. My name is Dr. Jamie Mitchell. I'm an endocrine surgeon and the medical director at the Norman Parathyroid Center in Tampa, Florida, and the director of the Division of Parathyroid Surgery at the Hospital for Endocrine Surgery, also in Tampa, where we operate. Incredible, one-of-a-kind hospital dedicated entirely to the surgical care of the endocrine surgery patient. For those of you who've joined us before, welcome back. New people joining us today, welcome. Thanks to everybody who sent their questions in. I've gotten a lot of feedback about these Q&A sessions with patients who have come to have surgery, and they really find it very helpful, so thank you. You're helping a lot of people with your questions. We have a lot of questions that have already come in. You're welcome to put some, post some in or post some questions through the feed. I'll do my best to get to them if I can, but we've got quite a few already. So let's begin. Question number one. Doctors have been watching my numbers for years. I'm assuming that they mean we're talking about calcium and parathyroid hormone levels. They say I have secondary hyperparathyroidism. I have kidney disease stage 3. My calcium is 10.1. That's elevated. For those of you listening, 10.1 is a little high. My parathyroid hormone level is 188. How long should I continue watching these numbers? Also, I have osteoporosis in my spine and hips. I do not know how to move forward. The answer about how long you should continue to watch this is no more time. You should have this treated. Your numbers show that you do not have secondary hyperparathyroidism. You have primary hyperparathyroidism. So you're being misinformed or misguided with this diagnosis. Secondary hyperparathyroidism means you have a high PTH value, not because of diseased parathyroid glands, but because something is causing them to make more hormone. There's a number of things that can do this. Having a high PTH by itself doesn't mean you have a problem. But kidney disease, which can do this, stage 3 kidney disease is not severe enough to cause a PTH of 188, and secondary causes of PTH elevation never cause hypercalcemia. So the fact that your calcium is 10.1 with a PTH of 188 means you have primary hyperparathyroidism. You have one or more diseased parathyroid glands. So you should have this treated. And the only way to treat this is with surgery, okay? That's a great question. The osteoporosis that you have, your parathyroid hormone hypersecretion is contributing to that in addition to other problems. And it's also probably making you feel poorly. You don't mention it on this question, but you probably have a lot of symptoms. So you should seek out an endocrinologist to guide you. If you're seeing an endocrinologist, then you should look for an experienced surgeon to take care of this for you. Thanks for the question. Question number 2. Once hyperparathyroidism occurs, is surgery the only option? Can a parathyroid adenoma ever act normally? The answer to the first question, if you're diagnosed with hyperparathyroidism, then surgery is the only option. There's no medical therapy to treat this. Okay, there's no pill you can take that manages it or makes the numbers better or prevents any of the end organ complications that parathyroid disease causes. It's a surgical disease in that regard. Okay, so the only way to fix the problem is to figure out which of your 4 parathyroid glands is abnormal, usually due to a benign tumor that's grown in it. That's the most common reason that this disease occurs. So you have to figure out which gland is the problem and remove it surgically. Okay. Fortunately, in experienced hands like those of us at this center, it's a very safe operation. It's fairly quick. Usually it takes between 15 and 30 minutes to perform. And the recovery is not a difficult one. There's some minor discomfort in the neck. You have a mild sore throat for a couple of days, but otherwise are pretty functional. Okay. Good question. Oh, can a parathyroid adenoma ever act normally? The answer is no. Like this doesn't go away. If you develop a parathyroid tumor, then you have it until it's treated. Okay. Okay. This is kind of a long question. My calcium has hovered around 10.5 for the past few years. That's elevated. Okay, 10.5 is a high calcium. And my parathyroid hormone is elevated. I also have worsening bone loss. I stopped taking high-dose vitamin D in January, but still get a lot of sun. Could high vitamin D be causing these results, or do they point to a parathyroid issue? My PCP is not concerned, and I can't get in to see an endocrinologist until November. It's really hard to get in to see an endocrinologist. It usually takes 3 to 6 months. So I'm not surprised. So first of all, taking vitamin D, it's a bit of a complicated answer, okay? Taking tons of vitamin D can actually make you hypercalcemic, okay? So if all I had was a high calcium level and you're taking a lot of vitamin D, then yeah, the answer is it's possible. If you take toxic amounts of vitamin D, that is something that can cause hypercalcemia. However, in your case, the vitamin D is not causing your problem because your PTH is really high. Okay, if you develop high calcium from taking too much vitamin D or hypervitaminosis D, then your PTH would be like 2 or 3, be very low. Okay, so this is PTH-mediated hypercalcemia. That means you have primary hyperparathyroidism. Okay, the vitamin D is not causing that. So I would stop taking the vitamin D if you haven't, and again, talk to your endocrinologist or primary care doctor about referral to an endocrine surgeon who can treat this. Okay. I've watched some of your reoperative videos, and you've mentioned both sestamibi scans and ultrasounds. What would be the reason for getting one versus the other, and do they sometimes show different things? Really good question. The answer is I always do both of those imaging tests. Okay, they provide different types of information, but the main goal, especially in reoperative cases, is a little bit different. Okay. For us, in our approach to surgery, the results of imaging tests for first-time operations is not that important to us. It doesn't really change the operation that we do. You can get more information about that on our website in terms of our approach. For reoperative cases, it's a little different. They're more difficult technically, and so having a target or having a better idea of where the disease is, which gland is the problem, is better. It's helpful. And in some cases, depending on what kind of surgery is done, it's necessary. And so these are the two imaging tests that I start with. And one isn't necessarily better than the other. They just give different types of information to me as I'm trying to figure out where the disease is. Okay, it's a good question. This is a really good question. How can you tell what gland is affected during surgery? Does it just look different? How does your experience help with this? So a couple things. When we do these operations, there's 2 evaluations of each parathyroid gland. So we always identify all 4 glands. And when they're identified, they're evaluated 2 different ways. One is visually. And does it just look different? The answer is yes. Parathyroid adenomas are markedly different in appearance compared with normal parathyroid glands. Okay? We were trying to get a couple of pictures that we could post so you could see the difference. And while I have a lot of photos of parathyroid tumors, I don't have that many of normal glands. I did find one though, actually. I just didn't have time to get ready for this live stream. So we'll maybe post them to our Facebook page or to the YouTube and add them so you can see the difference. But they're very different looking. Okay, so while we do the visual test, we also do a functional test. Okay, so parathyroid tumors are, as I said, are pretty obvious. They're obvious when you look at them. We don't really need to test them functionally to know they need to be removed. What's important in our approach is when we identify glands, even if they look pretty normal, we still test them functionally, okay, with a little biopsy, and then we measure the counts from that biopsy. That correlates to metabolic activity and function. And the reason we do it is that while the visual inspection and the functional inspection usually correlate with each other, there are times when a gland can look pretty normal, but the functional test is much higher than expected. So even though the gland looks normal visually, functionally it's abnormal. And so that helps us or guides us that gland needs to be removed even though it looks pretty normal. So it's very helpful in those cases. And that's what radio-guided parathyroid surgery means for us. It doesn't mean we use a probe to guide us to the disease in the neck. The probe is nowhere near the patient when we do these operations. But the probe is used to measure the counts in the tissue, and that helps us to understand whether it's normally functioning or not. So it's decision-making guidance rather than location guidance, if that makes sense. Okay? Okay, my doctor ordered a sestamibi scan, but due to claustrophobia, I could not do it. My calcium is elevated, I have all the symptoms, etc. Is there any way around the scan? So a couple things. I don't know how far along the process you went if you just saw the machine and decided you couldn't do it. For those of you who don't know, we have a video that shows exactly how the scan is done. It's going to be posted to our Facebook page, so you can take a look at it if you want. And I kind of describe in the video how it works. But there are a number of people who are claustrophobic, and even though you're not inside anything for this scan, the camera does come pretty close to you. But it's a pretty easy thing to manage. We just give the patients a little anxiolytic medication, a little Versed, which is like an IV Valium type medication, and that takes care of it. Patients do just fine. Can you do the operation without the scan beforehand? You can, but we lose a tool that we like to use during the operation, that functional test of the glands, as I told you. And frankly, the Versed really helps everybody. I've never had somebody who gets the Versed not be able to tolerate the scan. It's a good question. Here's an interesting question. If there is an ectopic parathyroid gland in the thymus, can you usually preserve most of the thymus? So a couple things about that. Lower parathyroid glands specifically are often located within the thymus. Okay, most people are like, what's the thymus? The thymus is a gland that when you're an infant is responsible for making your blood cells. And then the bone marrow kicks in and the thymus sort of stops doing that role. And we, until recently, thought it didn't do very much. But there's some recent information about the thymus that it has a role. And so people have become concerned about during parathyroid surgery that we take out the thymus sometimes. They think it's a big deal and they're worried about it. So the short answer is yes. Lower glands or lower parathyroid tumors within the thymus, you don't need to really remove a great amount of thymus or any thymus, frankly, to remove that parathyroid tumor. There are times when there are parathyroid tumors that are within thymic tissue lower down in the chest, not the thymic tissue that's in the neck. And in those cases, you often do have to remove some thymus to get them out of the chest. But even then, it's important to remember it's a minority of your thymic tissue. So any important function of the thymus that are being discovered, you're still going to have that. We don't take all of the thymus out. Okay? But it's a question that's come up recently. Okay. This question, I get this a lot. I have high calcium. Does that mean automatically that I have a parathyroid problem? The answer is no. There are other things that can cause hypercalcemia. The list, or the differential diagnosis list for hypercalcemia is relatively small. And to be honest, if you're a normal person just living your life, not really sick or hospitalized, and you're hypercalcemic, the most likely reason for your hypercalcemia is hyperparathyroidism. So a normal workup should be done to figure that out, but it's really easy. You just repeat the calcium with a parathyroid hormone level, and you'll know for sure. But most likely, if your calcium is high, that's the cause for it. Okay, what's the risk? This is something that people are really worried about. Okay, what's the risk of vocal cord damage or other complications from surgery? So the risk is really low. Okay, there's really three risks when you do a parathyroid operation. Okay, there's general risks that you have with any surgery. Okay, bleeding associated with the surgery or infection associated with the incision or the surgery. Those are general risks really with any surgery. Those are also possible with a parathyroid operation, but both are incredibly rare. Okay, bleeding and infection, while possible, occur in a fraction of 1% of patients who have this surgery. So really uncommon. Okay, vocal cord damage. It's not really damage to the vocal cords that we're talking about. It's the nerves that control the muscles to your larynx and therefore the vocal cords. They're called the recurrent laryngeal nerves, and they run behind the trachea as they go up to the larynx, and the parathyroid glands are near those nerves. And so we always operate near those nerves. Obviously, in experienced hands, that's why you want an experienced surgeon for something like this. We can do that safely, and the risk of inadvertent injury to those nerves is incredibly low. Again, a fraction of 1%. Okay, there is a risk of changes to the voice, but it's, as I said, really low, almost always temporary as well. And those are really the three main risks of this operation. Okay? Voice changes, infection, bleeding, all of them occur a fraction of 1% of the time. So it's a very safe operation in experienced hands. Okay? That's a good question. Before surgery, almost everybody tells me that they're a singer. They sing in the shower, they sing in their choir. So everybody's worried about their voice. And we are too. So good question. Is your approach different from other surgeons, or what makes your center unique? I talked about it a little bit. Our approach is different. The majority of surgeons in this country do use imaging results to guide their surgery, and so they try to do what's called focal parathyroid surgery. They hope an imaging test shows a signal or shows evidence of what they think the parathyroid tumor is. And then during the surgery, they focally go to that area, remove what they think is the tumor, check hormone levels, okay, before and after removing it, and hope to see it drop by a certain percentage to predict cure. We think that approach will miss abnormal glands up to 30% of the time, and there's data from other centers. Cleveland Clinic, for example, did studies about this that confirms that. So even when parathyroid hormone levels drop by meeting Miami criteria, which is a 50% drop, up to 30% of the time it can miss abnormal glands. So in our opinion, the only way to be sure that the patient is cured is to evaluate and identify all 4 parathyroid glands. So that's, most surgeons don't do that, that's a bit different. And then the way we evaluate them with the functional tests that I talked about earlier really is different than anyone else does. Let's see, what is your success rate with parathyroid surgery? How do I know you'll fix the problem the first time? You don't know for sure. Nobody cures everybody the first time, even us, even though we're as experienced as we are. But the success rate is 99%, probably a little higher. There are certain scenarios that even with our experience, we just can't figure that out the very first time. Parathyroid tumors that are in unusual locations that don't show up on imaging, for example. Even when that occurs, we can usually get to them, but there are certain locations we just can't get to surgically unless we know ahead of time. So there are rare instances where we can't find the tumor during the first operation. But what happens a lot of times, and I see this with the reoperative surgeries that I do, if we're not successful, then we're going to continue to work at it with you until we figure it out. And a lot of patients at other places or who had surgeries that aren't successful, and it happens, a lot of times they're kind of left without a plan. They don't know what to do. That's one of the reasons I started doing the reoperative videos that we mentioned earlier. So success rates are very high, 99%. Good question. Let's see, another great question. This comes up all the time. I'm showing no adenomas on my scan that I had. I only have high calcium and high PTH. What does this mean? Okay, it means that you have primary hyperparathyroidism and you should have surgery to treat it. Imaging technology, this is a really important concept. Imaging technology for seeing abnormal parathyroid glands on imaging tests like sestamibi scans or ultrasounds or CAT scans, the technology just isn't very good. The sensitivity is relatively poor, and probably half the patients we operate on the imaging tests don't show anything. If you understand parathyroid anatomy and embryology, you should not need an imaging test to tell you how to find parathyroid glands. And so the fact that your imaging test doesn't show anything has no bearing on the diagnosis. Okay, scans are not good enough to be useful diagnostically. The only thing that matters are your blood tests. Calcium high, PTH high, that means you have this disease. I know you have a parathyroid tumor because of that biochemical data. I don't need a scan to tell me that. Okay, so the diagnosis comes entirely from your lab data. So you definitely have hyperparathyroidism if you have high calcium and PTH, and you should have it treated. Okay. Negative scans don't change that. Let's see. How can I get my doctor to order the lab test for this disease? I know I have high calcium, but he doesn't seem to take my concerns seriously. It's a really good question, and I'm always shocked at how hard it is for some patients to get their doctors to test these labs. It's just a lab test. You go to your doctor and you say you have hip pain for a week, they'll order an MRI that costs $6,000, but they don't want to check a PTH value. If you struggle to have your doctor check the labs, I would just keep at it, and usually they'll succumb. But stay tuned. We're talking about maybe having a partnership with a nationwide company that provides lab tests to patients. They can choose certain panels and order them for themselves. So stay tuned. There may be more to come with that, but in the meantime, keep asking your doctor for it. And it always baffles me why they're unwilling to check that hormone level. It's just a simple lab test. Well, let's see. Here's another one. So I was diagnosed with osteoporosis in my 40s. That's pretty young, obviously. Could this be related to my parathyroid? Yeah, it's possible. Without lab data, I don't know if you have a parathyroid problem that's contributing to that. Bone loss is often multifactorial, meaning there's a number of things that can contribute to it. Heredity, genetics, your lifestyle, things like that. Certainly, if you have hyperparathyroidism, then yeah, that's a modifiable reason that causes accelerated bone loss that should be treated. But just being diagnosed at a young age certainly doesn't mean for sure that you have a parathyroid problem. I think everybody who's diagnosed with osteoporosis at age 40 should have a thorough, workup to make sure you don't have hyperparathyroidism, because that's modifiable. You can't modify your genetics, you can't modify your heredity, but you can fix parathyroid disease. That's a good question. This one just came in. It's a good question. I get it a lot. Okay, while awaiting surgery for hyperparathyroidism, is there anything we can do to mitigate the symptoms? And usually the answer is no. The only thing that I've found that can help some people is staying really well hydrated, which you should do anyway. If you have hyperparathyroidism, you're essentially getting dehydrated by the hypercalcemia. It acts like an osmotic diuretic. That's why one of the symptoms is polyuria, or having to urinate frequently. And so calcium, just like any electrolyte, is just a concentration, right? And so the more blood volume you have, the lower that number will be. So staying really hydrated can keep that number down or lower it. And I have had patients who have told me that helps them feel better. That doesn't mean it will for everybody, but it's certainly worth trying, and it's the right thing to do anyway. How are you doing on time? Good? Okay. Let's see. I am 7 months postpartum. This just came in as well. My calcium is over 11, and my PTH is 265. The recommendation for me was to take 10,000 IUs of vitamin D and 1,000 milligrams of calcium. Thoughts? My thoughts are that you should probably, whoever told you to do that, you should start seeing a different doctor. Calcium over 11 is obviously clearly high by anybody's standards. The PTH value means you have hyperparathyroidism. And I see this, it's a great question because I see this done a lot, this mistake done, even by endocrinologists who should know better. But while severe vitamin D deficiency can cause your PTH value to go up, okay, it never, ever causes hypercalcemia. So if your calcium's high and your PTH is high, often doctors will tell their patients, just like here, take a bunch of vitamin D, let's get your vitamin D normal. I'm assuming your vitamin D is low, maybe it isn't, but let's assume it is. They give you a bunch of vitamin D to see if that corrects the problem, and it will not fix the problem. So again, just to reiterate, vitamin D deficiency never causes your calcium to be elevated. So if your calcium's high, vitamin D is not going to fix it, okay? You definitely should not be taking calcium. Stop that immediately. You don't want to take any calcium.
You can keep going.
Okay. Okay, let's see. I had a gland, this just came in, had one parathyroid gland removed in 2018. I have another adenoma confirmed, I'm assuming by imaging maybe, or by lab data. But I was told I have too much scar tissue for surgery. What should I do? It's a great question. Anytime you've had surgery in any part of the body, the neck is no different. It's harder to do it a second time. Okay, the things that we do with surgery cause changes to the tissues, healing, and the inflammation of that process causes changes to the tissues. We call it scar tissue. But really, it distorts the tissues, it changes them, it changes how they look, how they feel, how they move. These are the things that we learn how to deal with as a surgeon. And so having surgery and having it heal changes those things. So yeah, it makes it harder, but that doesn't mean it's impossible. We do quite a bit of reoperative parathyroid surgery in this practice. I do an awful lot of it. It's probably my biggest area of interest at this stage of my career. And the approach is a bit different, but we can almost always solve these problems. So having had surgery before, if it wasn't successful or you've recurred and you have recurrent disease, which happens, there's no reason because you've had surgery that you can't be treated. So find someone who's experienced with reoperative surgery. I would love to take a look at your case. Go to parathyroid.com. You can very easily do the intake form, and I'd be happy to help you. Okay. Okay, here's a question. We get this a lot. People are nervous about this. How much radiation is involved with a sestamibi scan, okay? I've refused them thus far. So sestamibi scans are nuclear medicine x-rays. What that means is you are injected with a radiopharmaceutical, a radioisotope, and that labeled isotope can be imaged using a gamma camera. So sestamibi scans specifically, you're injected with what's called technetium sestamibi. The sestamibi is actually the delivery system. It's a chemical taken up by certain types of cells. Technetium is the radioisotope, and so that allows you to then image that collection of sestamibi wherever it collects in your body, hopefully in parathyroid tumors. That's the hope. So the amount of radioactivity is incredibly low. It's a very low dose. The exposure is very low. It's out of your system rapidly. Okay, within a couple of hours, the sestamibi is out of the system. And so it's a very low. I mean, everything we do in medicine, imaging tests, CAT scans have some risk. There's radiation with CAT scans, etc. But the risk and exposure of radiation for these traditional nuclear medicine X-rays is very low. Okay. And is that all we have time for? Keep going. Okay. What causes parathyroid disease in the first place? Is it genetic? In most cases, we don't know what causes it. Okay. The only environmental factors we know that can cause hyperparathyroidism, number one is ionizing radiation to the neck. A common cause for this, or we see this in patients who are treated for Graves' disease with radioactive iodine. Parathyroids obviously are very close to the thyroid, and the dose of gamma radiation with radioactive iodine is high enough that it can cause tumor formation in parathyroid glands. Usually it's delayed by about 10 years or so. So radiation can do it. People who take lithium long-term for bipolar disorder, long-term lithium use can cause hyperparathyroidism, usually due to foreign disease. It's a bit of a different process, hyperplasia of the parathyroids. Those are the only two environmental things that can cause the disease. Is it genetic? It can be. Usually doesn't. Most cases are sporadic, as I said, meaning we don't know what causes them. But there are certain genetic mutations that can cause parathyroid disease. They are typically associated with tumor syndromes. The most common of these really rare syndromes are the multiple endocrine neoplasia syndromes. We don't start thinking about a genetic or hereditary cause for parathyroid disease until you see 3 first-degree family members who have the disease. So siblings or parent-child relationships. Okay, it's a common question. Keep going. Okay, here we go. Back in 2018, I had 2 bad parathyroids removed and everything was great. I'm not sure what my other 2 glands are doing because recently my calcium was low and my PTH, my parathyroid hormone was high. I'm taking calcium supplementation to remedy this. Is this correct? What could be going on? Yeah, I mean, there's a number of things that could be going on here. And as I mentioned before, just having a PTH that's elevated does not necessarily mean anything bad is going on or that you have a problem or parathyroid disease. Okay, things like low calcium and vitamin D can cause your PTH secretion to be higher. That's a compensatory response. That's what it's supposed to do. If your calcium's low, you're supposed to make more parathyroid hormone to help correct that. I'm not sure why your calcium is on the low side. Malabsorption can cause it. There's a number of things that can do that. But it sounds like the parathyroid hormone being high is a compensatory response. Your glands are doing what they're supposed to do. Taking the calcium supplementation to try to correct that is the right thing to do. Okay. I think this is the last question. Okay. If I confirm high calcium and PTH with blood work, is that enough to come see you? Do I need imaging prior? Great question. You do not need any imaging. It's not going to change anything about what we talk about or what we do. As I mentioned before, the imaging tests are not good enough to be useful diagnostically. So they don't play a role in figuring out if someone has parathyroid disease or the decision to treat it. And so if you have the biochemistry, that's all that matters for the diagnosis. PTH is high, calcium is high, then that is 100% enough for you to move forward and contact the center for evaluation. Okay? Okay, that was a lot of questions, a lot of good ones. Thanks again to everybody who sent the questions in. Thanks to everyone who joined, and look forward to the next one. Probably another month or 2 we'll do another one. This will be posted on our YouTube channel if you want to take a look at any of the questions again, okay? Have a great day. Till next time.